going to start talking about the different etiologies, different pathologies, and understand how we can take care of these different conditions that we find on our patients. And the first type of wounds that we're going to discuss are acute wounds, which we haven't been talking too much in the past few years. However, the discussion about these type of injuries has increased quite a lot. We are alluding to skin tears. And skin tears were first discussed in the early 1990s by Payne and Martin, where they had a publication in 1993 referring directly to this type of injuries, which are predominantly found in geriatric patients, but can also be found in neonates, especially preterms, where basically we are talking about trauma that happens on the skin of these patients. These are acute wounds which should heal in the normal healing trajectory within 7 to 14 days. However, can become complex because these wounds happen on patients who are usually, their health is compromised. In the past few years, we had the establishment of the International Skin Tear Advisory Panel, better known as ISTEP, that have created a lot of awareness, thankfully, about these injuries and giving us also guidelines on how to manage them. So if we look at the definition from ISTEP, it's suggested that these are a traumatic wound caused by mechanical forces, including the removal of adhesives. Severity depends on the extent of the damage. We talk a lot about pressure ulcers or injuries, and good enough because we do need awareness about these, but unfortunately the awareness and education regarding skin tears is quite lacking. Remember, however, that skin tears are a lot more common and we have a lot more incidence of skin tears than pressure injuries, with the unfortunate aspect of it that because some clinicians are not aware what skin tears are, we misdiagnose them and sometimes over mistreat them. In point in time, one of the examples that I can bring is that there was a very nice publication that came out from Singapore. It was also featured in the Singapore Times, where they did a small audit over 144 patients, where they found in this hospital that 14 patients had skin tears. However, only one of them had a dressing gone and only 4 were noted in the nursing records. This is because many people misinterpret what skin tears are, or they don't even think that they are very important, but these are traumatic wounds. These are wounds that will cause anguish and pain to our patients, and we definitely need to take care of them. So as we said, the highest prevalence of skin tears will be found in the extremes of age, because the skin is not either in neonates or mature, or else in old age, the skin is more fragile because of less elastin, less collagen, etc. However, you can also find skin tears in patients who are critically ill or chronically ill as well. When we're looking about skin tears, it comes in direct combination with skin frailty. There's quite a few documents published about skin frailty, about an umbrella terminology that looks about the fragility of the skin in some of our patients. And in this population, there are factors that affect the skin. Some of them are modifiable, some of them are not. For example, if we're talking about pruritus, if we're talking about dry skin, nutritional status, these are things that can be modified. However, there are non-modifiable things. For example, definitely, we cannot reduce the age of these patients. We cannot change their sensory impairment, and definitely if they need care in their activities of daily living, although they still will need a need, however, we have to take care of how to provide this. Skin tears can happen everywhere, but in the two different populations, the number of skin tears, for example, in geriatric patients, they're usually in the upper arms, mostly on the dorsal of the hand, but can also happen in the lower legs because these are the areas which are most exposed to trauma. When it comes to the neonatal, especially the preterm population, these skin tears are mostly associated with removal of adhesives and are most commonly found on the head or the chest of the patients. So how do we identify the risk? And one of the good things that happened is that ISTEP have provided us with a consensus document, which I suggest to you to find and read, and they give us an extensive way how to determine the risk assessment of these patients. So we have to look at the general health of these patients, looking at their mobility, looking at history of skin tears, history of falls, and also looking at their physical environment to try to make it as safe as possible. So the issue is, how can we prevent them? And preventing them, although they will still occur because of the very fragile skin these patients might have, however, we can be very careful when we're providing the routine care for these patients, managing their ADLs, provide protection from self-injury, for example using mittens in patients who are scratching or who can be aggressive, creation of a safe environment, trying to remove any objects from the room that will incite falls or incite trauma, and making sure also that when we are lifting and handling these patients, we use a safe way and we use devices like hoists and slide sheets that will make the handling of these patients easier for us and more safe for these patients. Make sure that these patients are getting the correct levels of nutrition and hydration. If they have any dressings or any devices, make sure that we are using adhesives which are not very strong. For example, using silicone adhesives that can be easily removed. Ourselves, things that we know and have known for a long time: avoid wearing jewelries, avoid long nails, and making sure that we are using tepid water rather than hot water when we're washing these patients, and using neutral pH cleansers as well. Maintaining the moisture of the skin, making sure that we are using hypoallergenic skin moisturizers not to allow the skin to dry out. However, one of the most important prevention strategies is education and awareness. The more we are aware of skin tear, the more we are knowledgeable about them, the more we are equipped to make sure that we prevent these injuries for these populations of patients. Like any other type of wound, there are different types of classification systems available. Obviously, one of the first that came out was the Bain Martin from the 1990s, where they had 4 categories depending on the extent of damage to the flap. All the classification systems that came after that had the same type of discussion about the flap. A few years later, we got the STAR classification system that actually had more categories behind it, but the most recommended and the most recent classification is the ISTEP classification that gives us 3 types. So the first type is we have a skin tear where the flap is not damaged and can be repositioned onto the wound. The type 2 skin tear is where we have partial flap loss, and the type 3 is where we have total flap loss. So it makes it more easy for us to classify these wounds. So again, another type of risk assessment that came out recently, again you will find this in your textbook, is classification of patients into 3 groups, and looking at the different groups at how much they are at risk, kind of the same type of risk assessment that we have for pressure injury with Braden, Waterloo or Norton. If a patient has a skin tear, obviously the objective for us is to heal that wound as quickly as possible. So the stages of management, the first one is trying to control the bleeding, because these wounds can bleed quite profusely, and remember, many of our patients will be on blood thinners, for example aspirin, so try to elevate the lymph wherever possible and use gentle pressure to try to stop the bleeding. Once that is done, then we start cleansing the wound very gently, ideally by means of gentle irrigation with a safe cleanser. The important part of management of skin tears is managing the flap when it is viable. So if we have a flap which is in a type 1 or a type 2, we have to realign the flap without stretching it, getting it back gently onto the bed of the wound, for example by means of using cotton tip applicators that you moistened previously and helping that flap back onto the wound. Once you've done that, the next step is obviously application of a dressing. The best dressings that you can use are non-adherent dressings. Avoid dressings which are considered to be less good when it comes to adherence. For example, when we're talking about creasy causes, probably the two best dressings that you can think about using for skin tears are dressings with technology lipidocolloid or with silicone. The difference between both is that while silicone is just a non-adherent dressing, which helps obviously a lot with skin tears, the technology lipidocolloid, apart from being atraumatic when we remove it, will enhance the moist wound healing environment. I personally try to avoid border dressings, however you can still use border dressings as long as the adhesive of the border is very easily removed. There are also foam dressings which have either the TLC or the silicone which are borderless. If you're using this, you can use bandaging, but don't use an elastic bandage, use those type of cotton bandages that don't apply any pressure. One important tip when you are dressing a skin tear is to draw an arrow in the direction of the flap. So when the next person comes to remove the dressing, they will remove it in the direction of the arrow, not to disrupt the flap. It is suggested to keep the dressing for longer periods, at least 5 days, not to disrupt the flap as much as possible. There are complications that can happen, and sometimes we opt to also use a local antimicrobial if our patients are at risk of infection. So the dressings which are suitable, as we suggested, are mostly the TLC dressings and the silicone dressings. However, the ISTEP document suggests that we don't use skin closure strips because these are very difficult to remove and will cause damage again. Obviously gauze, because it will dry out. Also iodine-based dressings will dry out the flap, and other dressings like films and hydrocolloids will be difficult to remove because of their very aggressive adhesive, and once you remove these dressings, then you will cause further damage.